I'm Michael Beuhler. I'm from the Carolinas Poison Center. I'm the medical director there. I'm going to be talking about this concise review of a 20-year of Amanita poisonings. Interesting paper. You can see by the authors they are French, which we will notice some of the things about that as we get to it. The paper begins with a little review of Amanita poisoning. The times they present are kind of odd, but I will present them in terms of what the different stages are. There's an incubation stage, or that's the stage where after you ingest it, you're without any symptoms. We traditionally think about it in terms of 6 hours. Others think about other ways. There's the gastrointestinal phase, which is marked by vomiting, diarrhea, and abdominal pain. And again, this is somewhat delayed compared to the other mushrooms. There's a hepatotoxic phase, which is marked by hepatic damage, and you start getting your progressive coagulopathy. And then the hepatorenal syndrome, or the fourth stage, depending if you're counting 0 as stage. The last stage is marked by seizures and renal injury and fulminant hepatic failure, and then death, as the authors. And I couldn't do a talk without a structure. So the toxins responsible are amanitins. There's alpha, beta, and gamma amanitin, and they only really differ by slight changes in the peripheral structure around there. And these are bicyclic peptides that are bridged by a sulfur atom, and you can see that substituted tryptamine in the middle there. Interestingly, these toxins use the transport system for biliary acids to get into the hepatocytes, which is important to remember for later when we talk about some of the treatments. It works by inhibiting RNA polymerase II, and this prevents transcription, which means that you don't make any new messenger RNA, and that's then going to limit your ability to make proteins, and then obviously then you're going to develop illness with that. Now the paper goes on to review a number of different treatments. I'm going to focus on silymarin complex for reasons that will become apparent when we get to the conclusions of it. The major compound is believed to be silibin. And there are some animal studies that have shown, and this is from milk thistle, and animal studies have shown some treatment benefit of this. Apparently, it's believed to compete with the alpha-amanitin, its cellular uptake into the hepatocytes by the bile salt transport system, which is what I alluded to on the previous slide. And that's believed how it works, but also it's got other fantastic effects. It's a radical scavenger. It has anti-inflammatory effects. It stimulates liver cell metabolism and growth. And there are some side effects, none of them particularly severe, including nausea, headaches, pruritus. One of the bigger problems of this, of course, will be our availability in the United States of this is very minimal. The paper also discusses other treatments. One of them I mentioned is NAC, which we know very well from acetaminophen toxicity, and talks about it being not only a free radical scavenger, but also being able to contribute to your glutathione stores as a possible mechanism for helping with amatoxin poisoning. So what this was a review of cases in the literature of human Amanita mushroom poisonings in North America and European countries for the last 20 years. And there were 2,108 cases, and there were 32 cases with liver transplants, and this is really a Herculean effort, and it's shown by the pages and pages and pages of tables that make up a big piece of this paper. The exact mechanism of how they chose which cases they used isn't really clear, but it does appear to be very thorough, and they list individually where they came from by state and everything. And they note the most frequently implicated mushrooms were actually all the Amanita species, although Lepiota and Galerina do have amatoxins. It seemed that it was mostly Amanita species that were responsible for these human cases. All right, so this is the hardest part of the paper to understand, so I'll take you through it slowly. They separated the cases into 11 different modes of care. There was supportive care only, then there was detoxification, which included oral detoxification, which was activated charcoal. It included all your extracorporeal stuff, your plasmapheresis, your charcoal hemoperfusion, all of those, hemodialysis. There's the benzopenicillin, which I'm going to abbreviate as penicillin. There's your NAC group. Then there's the silibin. Okay, so those were individuals. Then they did groups of things. They did silibin penicillin, penicillin antioxidant, penicillin steroid, penicillin thiotic acid. And then the last two groups were penicillin plus at least one other treatment and psilocybin. And then the last group is penicillin plus at least two other treatments without psilocybin. So those are triples or more. And for assignment to the different modes, with the exception of the detoxification group, they ignored any detoxification procedures that were done for any particular patient. So you can look at the rates of drug therapy use, and this is interesting because the benzylpenicillin was the most frequently used one at about 87%. Psilocybin was used about 38%, steroids 27%, and NAC was used about 12% of these cases. Overall survival was around 90%, and the mortality rates were broken into transplant included and transplant excluded. Where they included the transplants, they counted them as those that died, and where they excluded, they removed it from both the numerator and the denominator. And the highest mortality rate was seen in the supportive measures only group, about 47%. And the detoxification group had a mortality rate around 10%, which was not statistically different than the pooled drug treatment groups, i.e. when you grouped all chemotherapies or all drugs, it was no different from the detoxification. So this is kind of the punchline of the paper. The lowest mortality rates were seen in, and there was no difference between these groups, psilocybin, NAC, psilocybin, and penicillin together, and then the triple penicillin plus something else plus psilocybin. And so unless the psilocybin was grouped, unless it was grouped with psilocybin, the penicillin or benzylpenicillin didn't demonstrate any effect. And I've starred those two because these two, psilocybin and the psilocybin plus penicillin, were the only two groups that were significantly different for the detoxification group, but only when you excluded the liver transplant patients. Now, I will note that there were a total of 11 groups plus 4 other combined for a total of 16 different groups, which meant that there were 15 squared times 2 comparisons, so around 450 different comparisons. There were no adjustments made for multiple comparisons, comorbidities, treatment location, age, detoxification therapies. Their conclusions are: benzylpenicillin did not demonstrate any treatment benefit, psilocybin is beneficial in decreasing mortality, and NAC is beneficial in decreasing mortality. And the take-home points are kind of taken right from the paper. The overall survival rate is around 90%, which I think is kind of pretty good. The overall mortality rates were lowest seen in the psilocybin and the NAC monotherapy group, and specifically pulling right from the paper, silymarin, and the active chemical is believed to be psilocybin, and NAC play a crucial role in the recovery of amatoxin poison patients, and clinical data does not show benzylpenicillin to be an effective drug. That's it.